The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome for the next episode of TMD Demystified. My name is Tony Urbanek. Today's episode is entitled The Integration of Dentistry and Medicine and TMD. I've touched on this topic before. I believe one other prior episode discussed it somewhat, but I'd like to take another look at it and discuss it today, because it is becoming much more popular and in the mainstream of dentistry to discuss how and why and under what circumstances dentistry should become integrated with medicine. So first, let's define our terms. So dentistry, historically, is a standalone profession that had to do with treatment of the structures within the oral cavity, primarily the teeth. And up until very recently, pretty much only the teeth and associated periodontal structures, alveolar bone, periodontal ligament, and related structures. And more recently, the profession has expanded its viewpoint into interest in other related structures, salivary glands, and most importantly, the concept that the oral cavity is the beginning of the alimentary canal, which prepares the food, not only just chewing, but salivary flow and the effect of salivation and saliva on preparing food for digestion. It all associated with the beginning of the alimentary canal, which is the oral cavity. And for that and other reasons, dentistry as a profession has taken another look at broadening the scope of the dental profession and broadening the scope of dental education to integrate it more with what is considered the profession of medicine. Now, medicine basically is the profession that deals with the diseases and symptoms associated with the rest of the body. So when you come to treating the body, you have two distinct professions. You have the medical profession, which basically deals with all other structures. I mean, that would include ophthalmology and ear, nose, and throat, otolaryngology, cardiology, the heart, pulmonology, the lungs, the surgeons who deal with musculoskeletal, orthopedic surgeons. You know, the medicine has all been broken up into specialties and subspecialties, but all under the umbrella of, quote, medicine. And dentistry, because of historical nature of education, has been segregated out as its own profession and limited to the teeth and related structures that I mentioned. Not necessarily for the benefit of the patient overall, because limited time in the educational process and because of expanding technology, both in medicine and especially in dentistry. The biggest thing, as probably much everybody knows, is that teeth now can be replaced with dental implants, which is a huge advancement over prior 1978, 1985, when the first dental implants came into view. But there is this growing interest and movement to integrate part, if not all, of dental education into medical education, and possibly even making dentistry a specialty or subspecialty of medicine, which actually, in my mind, and some would disagree and some would want to debate it with me, but makes logical sense. It takes a lot of time to educate a dentist to do what is traditionally called dental surgery, basically dental surgery on teeth, dental surgery, which then was expanded into periodontal surgery, surgery on the associated structures around the teeth, the bone, and the periodontal structures. And then, of course, with oral and maxillofacial surgery, now validly so, associated with the entire maxillo, upper jaw and lower jaw, facial surgical procedures, which would include orthognathic surgery, cosmetic facial surgery, which would include facelifts, rhinoplasties, cleft lip and cleft palate, cancer reconstructions, cancer ablation. Subspecialties within oral and maxillofacial surgery is now trained to do that, which rightfully should be the case, because actually the oral and maxillofacial surgeon, of which I am one, boarded, trained, with both dental and medical degree, is really our specialty revolves around the skeleton of the face, fixing, adjusting, treating trauma to the maxillofacial region. And of course, because trauma to the bone goes along with trauma to the soft tissue, we get very skilled at soft tissue reconstruction of one form or another. Obviously, at times competing with plastic surgeon and ENT surgeons, but rightfully so, each of those specialties has a part to play and can part to play depending on training with surgery on the face and associated structures. But the maxillofacial surgeon primarily has its interest in the skeleton of the face, and correctly so. We are the experts on the construction and reconstruction of the facial skeleton. Along with the facial skeleton comes the jaw joints, because the jaw joints are part of the facial skeleton. Basically, the oral and maxillofacial surgeon is the orthopedic surgeon of the face. Another way to describe it. And so when one speaks about the integration of dentistry and medicine and oral and maxillofacial surgery and surgeons as a specialty within dentistry, not medicine, although at least half of the oral and maxillofacial surgeons now also have a medical degree. So there's a lot of integration and overlap already. But in treating the body and treating patients, it really all boils down to who has the best training, who has the best training and spends the most effort on the science associated with doing the appropriate procedures and learning about that. But admittedly so, ENT surgeons, plastic surgeons, and oral and maxillofacial surgeons who, to some degree or another, can compete, but shouldn't necessarily so. It should be the specialty, the doctor himself, who has the best experience, the best knowledge in treating a particular circumstance or disease, which gets the best effect. That is a preliminary primer to what I would like to say about TMD and the integration of dentistry and medicine. Historically, TMD, temporomandibular joint disorder, was literally inappropriately given to the dentist as a problem to solve and treat, because the first article written, that to my knowledge, which describes symptoms of TMD, headache, earache, jaw pain, ear pain, was written by an ENT surgeon in St. Louis, Missouri in 1934, published in a journal in 1934 by a Dr. Costin, Costen, and that is why for the first 2 decades of the problem with this joint, the symptoms associated with this joint, the problem with this joint was called Costin syndrome. He wrote the first paper, and thereafter it was called Costin syndrome meaning associated symptoms in one particular problem. And the associated symptoms that he wrote about were primarily ear pain, jaw pain, pain extending into the head and the jaw, and even headache. Headache, earache, jaw pain, neck pain. Those are the 4 primary symptoms of Costin syndrome, which then led to temporomandibular joint disorder, which inappropriately is called by almost everyone TMJ, the name of the joint. Appropriate name is temporomandibular joint disorder, singular, not plural, because the disorder is only one disorder. And that was my discovery, that chronic inflammation within the temporomandibular joint creates all the symptoms. The symptoms are not created by too much motion of the jaw, although that's called bruxism. Too much clenching or grinding can cause muscles to get tired for sure, but that does not cause all of the symptoms. The symptoms related to TMD, temporomandibular joint disorder, singular, created by chronic inflammation within the temporomandibular joint, are now known to be and agreed upon to be by everyone. The symptoms of TMD are frequent and or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, feeling of fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are accepted symptoms of TMD. Now, those are very disparate symptoms. And what confused everyone, the dentists, physicians, and the patients for decades, were how can each of those symptoms be related to this joint in particular? And that's what it took me to figure out, basically. And it wasn't that hard when you know where to look and you had a little bit of knowledge about cell biology and gross anatomy, which is one of my trained areas, master's degree in cell biology and anatomy besides dental and medical degree. Because I had the broad background and research background with 2 years of fellowship with the National Institute of Health, I took began an independent look at how in the heck this joint can create all of these disparate symptoms. And all of these symptoms in anyone's mind, in a patient's mind, must be associated with medicine and not dentistry. I mean, if you have upper back and shoulder pain, one would not necessarily be looking at this joint as the source. Obviously, if you have frequent or recurring headaches, one would not necessarily be looking at this joint to create those chronic and constant headaches. But as it works out, there is a mechanism that can be described easily and proven that chronic inflammation within this joint can actually create each and every one of those symptoms. And if you can decrease the inflammation, alleviate the inflammation within the joint, all of the symptoms disperse and go away, don't occur. That has been proven. So if you are talking about why and how, whether it's valid and appropriate to integrate dentistry and medicine, the study and treatment of TMD disorder, temporomandibular joint disorder, is the best example to confirm that there should be an integration of dentistry and medicine. This joint by itself and chronic inflammation, which is basically the study of cell biology, and gross anatomy, which is the study of the gross structures in any particular area of the body and how that relates to allowing inflammation to create each of those symptoms. That is what I've studied, that is what I've proven and can show and discussed in detail in other episodes exactly how chronic inflammation in this joint can create headaches, earaches, jaw pain, neck pain, ringing, fullness, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and even exemplified in my most recent last episode, of people having chest pain in the area of the pectoralis major and minor up here in the upper chest, thinking they're having a heart attack. How close could one be to perceiving that this must be a medical problem, and people going into the emergency department with terrible chest pain, thinking they're having a heart attack, when actually this chest pain is originating and created by inflammation within the temporomandibular joint. And I've discussed that in the last episode. Go back and read it. Read the blog and read the episode that talks about how you can get upper chest pain when you have inflammation in this joint.